Storing medication safely. When it comes to medication storage, the number one rule that you must keep in mind as a med tech is to always keep medications locked. This includes when your cart is on the floor. Never, ever leave medications on top of your cart and walk away. You must store unlocked within the locked area, so aka the med room. Keys only are accessible by authorized personnel and never leave the facility. And what we mean by this is don't have your keys on top of your med cart. Always put them in the secure location and never keep your keys in your pocket. We had an employee one time who went out for a lunch break, had a car accident, and we were not able to get into the med cart because she took the med keys with her. Narcotics counts are done daily from one shift to the other. Never, ever leave your med tech shift without doing a narcotic count with the other oncoming or offgoing med tech. You must remember that this is a controlled legal substance. And if the count is off and you do not do a med count, you are then resuming responsibility for said medications. Disposal of any narcotics always requires 2 employees. This must be witnessed, signed, and dated, and the amount that it was destroyed recorded in the patient's record. Never, ever do a narcotic medication destroy alone. Expiration dates on narcotics must be checked regularly. So when we're looking at the narcotic med count, you must review any discrepancies with the administrator, or if you're in one of our larger facilities, with the director of nurses or the clinical liaison. So, for example, if we show that Mrs. Smith should have 25 narcotics in her med count, but is only showing 23, this must be brought to the attention of the administrator or the clinical liaison or director of nurses right away, and a full audit must be done. You are responsible for any suspected drug stealing. So if you are doing a narcotic count and it's one off and you suspect that somebody is pocketing these medications, it is your legal responsibility to report this. If you don't stay for the narcotic count, you're as responsible as the person who is not staying for, or who's staying behind but not making you being held liable. So at the end of the day, when it comes to the storage of medications and the narcotic count, these things always must be done. There is no ifs, ands, or buts. This also goes to when we are receiving in meds. I or any other senior administrator should not be able to walk into a medication room and see meds outside of the medication carts. They should always be securely in the med carts, put away. They should not be sitting on top of a desk in a box. They should not be sitting on the floor next to the med cart. They should be properly stored at all times. So we're going to move to the medication administration record, also known as the MAR or MAR. So when we're looking at a MAR, there are several key components that we must keep in mind. The name of the resident, the medications, the strength, the dosage, the route, and frequency. We're going to review the name of the prescriber and expiration date of the medications. Allergies need to be clearly marked on the MAR, date and time of medications to be given as well. initials, signatures, and titles, and any new orders. So the MAR is where we're going to take and put all the medications that one resident is receiving onto one easy to read document. So this kind of goes back to our 6 rights, and this is going to go back to our triple check. So this is part of the triple check is the MAR. So we're taking the prescription bottles, and we're taking all the physician's orders. And bear in mind, most of our residents have multiple physicians. And we're making sure those two things match up before we put them on the MAR. Discontinued or changed medications should be highlighted if discontinued. New or changed orders is written clearly with all the above requirements, as mentioned before. Get a new label from the pharmacy as soon as possible, or request a new bubble pack if it does not match. Do not give the medication until the new label or new bubble pack is given, and you must document why. So, for example, if Mrs. Smith has a blood pressure medication that she should be getting 2 times per day with 2 pills at 10 milligrams each for a total of 20 milligrams, and the bottle says 1 pill twice daily, obviously there is a discrepancy. So what we're going to go to is now we're going to go to the order. What does the order say? Well, the order clearly says it should be 2 times per day, 2 tablets at 10 milligrams each. So what we're going to need to do is we're going to need to call the pharmacy and let the pharmacy know that the order and the bubble pack and or bottle label does not match. And so they need to reissue a new label, or they need to reissue a new bubble pack. Refusals, if there's any refusals of medications, these need to be addressed right away. You must document these. There are some refusal of medication forms that have been created to help make it easier for you guys to document this. But also, we must reattempt to give said medication. Even if we know every day Mrs. Smith refuses that blood pressure pill, we still make 2 attempts to give that medication. It is also important to know that after the 2nd day of Mrs. Smith not taking said medication, you must do an incident report in order to document to the state the reasons why she's not taking said medication. You must reach out to your director of nurses, your clinical liaison, or your administrator to inform them that Mrs. Smith is not taking said medication. Also, within the pharmacy MedTech communication log, you should be filling out that Mrs. Smith is not taking said medication and faxing this into the doctor. When we have a resident who is chronically not taking their medications, I cannot stress this enough, we don't just simply ignore that fact and keep documenting it. We need to pick up the phone and have that conversation with the physician about either A, changing the medications and the reason why Mrs. Smith isn't taking said medications. Maybe she's feels too dizzy with it and she's afraid that she's going to fall because of the side effects. So we need to be good advocates for our residents, and we need to pick up the phone and have conversations with the physicians when medications are being refused and why. And we also need to talk to our administrators about this. Our administrators and or directors of nursing or clinical liaisons will be the ones to have the conversations with the families about why someone is not taking their medications. because sometimes as med techs, we could say maybe the wrong thing that could upset a family about a reason why if a loved one's not taking their medications. So those kind of delicate situations, we will go ahead and handle for you guys unless otherwise instructed by your administrator, director of nurses, or your clinical liaison. The other thing you guys need to understand is if for some reason a medication is out, this also, after 2 days, must be reported to your clinical liaison, your administrator, or your director of nurses. Do not just simply keep documenting and saying, medication missed. You must do the MedTech communication, send that into the pharmacy, send that into the physician, and send that into your supervisor. After 2 days of said medication being out, we have to report this to the state. This is something as a med tech, you guys must really keep in mind that at the end of the day, the state might come in and question you as the med tech and say, why was this person without their meds for more than 2 days? Did you follow all of Del Monte's policies and procedures when it comes to medication administration? Did you document said medication being missed or out? Did you, in writing, inform the physician, which physician, what date, and what time, or times and dates that you informed them? Same with the pharmacy. And did you communicate it with your supervisor? I cannot stress this enough. It is your guys' responsibility to communicate this with your supervisor when a medication is not given because it is out or because the resident is refusing. When this happens on the MARM, you're going to, if the medication is given, you're going to initial. You're going to circle if it was refused or augmented, and you're going to notify the doctor. So I'm going to pop quiz you guys when I'm on site, and I'm going to ask you about what is your responsibility when it comes to missing medications, lack of medications, or refusal of medications. You guys should know that this is a very serious ordeal if a medication is not given for any reason. PR medication indications for use. Any special precautions, limits on dosages, allowable dosages in a 24 hours. We're going to chart date and time, the reason, and most important, the effects of the medication. So when we're looking at the PRN orders, we got to remember that there's a max dosage for a 24-hour period, and there are certain parameters for a reason why somebody might get a PRN medication. PRN medications must be followed up after being given for how they are affecting the resident, and this must be documented. Pain was relieved. Pain is no longer a 9 out of 10. It is now a 4 out of 10. Anxiety levels, agitation levels are down to a manageable level. So once again, if we don't document the post follow-up, we don't know how effective this medication is going to be. And this is extremely important for us to remember because sometimes when we look at PRN medications actually now become a set standard order if we need to. So especially when we are dealing with like agitations and behaviors, a lot of times we'll start medications off as PRNs. Our Xanaxes and other behavioral meds will eventually turn into a standard order for our residents. Refills. So for our pharmacies that are on auto refill, please, 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 please do not rely on, oh, they're going to auto refill it. They're going to auto refill it. Still do your due diligence. Fill out the MedTech communication to pharmacy and to the physician what medication needs to be refilled. and send it in. So that way we have written documentation that we did our part for requesting said medications. Because here's why. Let's say there's a glitch at the pharmacy, and for some reason, Mrs. Smith's blood pressure medication comes off of auto refill. And we're coming up to day 7, and now day 8's come, day 9's come, and we've not gotten that refill of that medication. Guess what? We are now 2 days when day 8 and day 9 hit with no medications. So we can't just automatically assume that it's always going to happen. The state's going to come in, they're going to audit Mrs. Smith's chart, and they're going to say, did you, as the med tech on shift for that day, when we knew we were on our 7 days last set of medications, did you, as the med tech, do a follow-up for a refill request? And if your answer to the state is, well, it's on auto refill, they're going to say that's not sufficient enough. Our duty as med techs is to refill these meds regardless if they're on auto setup or not, and document this. So I cannot stress this enough. All meds within 7 days, when you hit that 7-day row and your bubble pack, it must be refilled, or 7 days left in the bottle. Keep in mind with narcotics in 2022, some of the narcotics rules for the physicians have changed. They are not allowed to refill narcotics before 3 days. Please still go ahead at day 7. Let's send in our medication refill request. And then at day 3, let's send that request in again. Now, the physician's not going to call it in probably until day 3, because that's the new legal standard from the DEA when it comes to narcotics. But you must go ahead and do that. If you send in for a medication request and you do not get that refill within 3 touch points, and what I mean by 3 touch points is you called it in yourself, that's touch point number 1, and you're on day shift, and PM shift follows up with a touch point to the pharmacy and or doctor. That's touch point number 2. Now we're coming into the next day, you're back on your AM shift. That's touch point number 3. So by the end of your shift, if you've not gotten a response from the pharmacy, medication request received, we'll be sending it out tomorrow on whatever date. Please notify your director of nurses, your clinical liaison, or your administrator. And here's why. If you're not getting communication back that these medications are on their way, these are time sensitive. And so you might need somebody else to help assist and ensure these medication refills are being done. No, it is your responsibility to notify us. I know on here it says if meds are not received by day 5, which yes, by day 5, you need to come back and remind us that meds are not in. But moving forward, the new policy is after 3 touch points. So when you're looking at that medication communication request that we have done up for you guys, the top part, we're filling it out, residence info, the medication that is being requested, the frequency, the dosage, and the pharmacy that they're using, and the doctor's name that's prescribing that medication. That's touch point number 1. Lines 2 and 3 in the middle for the other med techs, that's touch point 2 and 3. So you guys cannot stress this enough. Medication communication log should also be used in your daily shift reports. So Jenny's coming in. Jenna is the off-coming med tech. Jenna's going to grab that communication log, or Jenny's going to grab that communication log, and we're going to open it. We're going to go back 3 days and we're going to see which one has been completed and filled in, which ones haven't, and those are the ones that Jenny is going to follow up on. So use the MedTech communication as part of your MedTech reporting. All right, so we are going to go into medication labels
Hey everyone,
video.
it's Sarah with RegisteredNurseRN.com, and in this video I'm going to demonstrate how to read a medication label. And whenever you get done watching this YouTube video, you can access the free quiz which will test you on this content. So let's get started. As a nurse, you want to be familiar with how to read a medication label because a medication label contains important information that you need to know in order to safely administer that drug to the patient. So what are some things that you can expect to find on most medication labels? You can expect to find the brand name followed by the generic name, the supplied form of the medication, the dosage strength, the route the medication should be administered, the total volume or amount of medication that's in that container or vial, the lot number and expiration date, medication instructions, which are very helpful for telling you how to store the medication or reconstitute the medication if needed, the manufacturer and distributor's name and address, a barcode, and the NDC number, which is the National Drug Code number. So now let's look at some medication label examples and look at where this information can be found. So here's a mock medication label. First thing I want to cover is the brand name. Here the brand name of this medication is Pretend Med, and the brand name is the registered name given by the drug company who owns rights to it. And you may notice next to this brand name a registered trademark symbol, which is an R with a circle around it, and that means it's registered. Now there are patent protection rights that are given to the company who will solely market this medication under its brand name. So there won't necessarily be a generic form of the drug available yet until this patent protection runs out. Now, once the patent runs out, other companies can market the drug and may create different brand names for a medication, but you should always be able to see the generic name as well. And the brand name is usually a lot easier to pronounce and spell than the generic name. And the first letter is capitalized, and it's usually the largest and boldest. Now, typically found very close by that brand name, usually under it, is the generic name. And here in this example, our generic name is fofarmoide. And the generic name represents the active ingredient in the drug, which is why many times the generic name is a lot longer and it's harder to pronounce and spell because these names are chemicals. Now, there is only one generic name for a drug. There can be multiple brand names, but only one generic name, and it will always be included on a medication label. Now, sometimes you may be looking at a label and you will just see a generic name, and this will be used for medications that have been on the scene for decades and they're very well known by this name. These names will typically have the parentheses around them and will all be in lowercase letters. Now, one thing that is helpful for us nurses is that the ending of most of the generic names tend to be similar for certain groups of medication, which makes it easier to identify what medication we're giving to the patient. For example, the generic names for ACE inhibitors typically end in pril, like lisinopril, or beta blockers. They tend to end in LOL, like labetalol. Now, as a nurse, it's very important to be aware of both the brand name and the generic name because the doctor or whoever's writing medications for this patient may write you an order for the brand name, but pharmacy supplies you with the generic name. For instance, the physician orders Lasix, but you're supplied with furosemide. You would know that this is the same medication. And the reason for this is because the generic form of the drug, whenever it is available, tends to be a lot cheaper than that brand name. So it's saving your patient hundreds to even thousands of dollars. And these medications work the same. It's just cheaper for the patient. So one thing you want to keep in mind, if your patient, let's say, is taking the brand name at home, whenever you go to administer that drug and it's the generic form, they may look at the pill and say, hey, this doesn't look like my pill I take at home. Are you sure that this is the medication? Well, after confirming it is, you want to educate the patient generic and brand names. Those pills, capsules, tablets, whatever, they tend to look different. Now, sometimes next to the generic name, you may see the letters USP. What does that mean? What does it stand for? That stands for United States Pharmacopoeia. And this means that that medication has passed specific quality standards and has a seal of approval on it. It doesn't represent a certain measurement of the drug or how the medication is released in the body, which leads me to my next point. If a medication is designed to be released in the body in a certain way, this type of release will be listed to the drug's name and it will be specified on the label. For example, here with this medication label, it says Pretend Med XR. XR is not its brand name. It is telling you that this is a different release of the medication. So XR stands for extended release, and that's even further specified a little bit lower on the label below the generic name. It tells you that these are extended release capsules. Now there's different types of releases. Some examples would be like CR, that stands for controlled release, IR, immediate release, EC, enteric coated, CD, controlled delivery. And the reason I point this out is because it's very important the nurse looks at this part of the medication label to verify what type of release this medication has. Because depending on the form, the medication may not be able to be crushed or chewed, because if it was crushed or chewed and it was one of these special releases, it could alter the rate at which the medication works in the body and could be not very good for the patient. Another thing you want to be familiar with on the medication is the supplied form of the medication. This tells the nurse how the medication is supplied. For example, here our label tells us that our medication is in capsules, but you can also have medications in tablets or even solutions and suspensions. And here you can see that this medication tells us that it is an oral solution, but this label tells us that it is actually going to be an injection solution because we're dealing with something that's going to go intravenous or intramuscular. You can also have topical, suppositories, etc. Next is dosage strength. This is the amount of drug that is in the specific dosage form supplied. And you will see a number with the measurement unit beside it. So let's look at this medication label of Pretend Med. Our dosage strength is 250 milligrams. So what does that mean? Well, a lot of times you can go and look at the medication instructions and it will give you further details about this. But what this means is that each capsule of this Pretend Med or fofarmoide contains 250 milligrams. So let me test you here for a second. Let's say the doctor orders Pretend Med and they order 500 milligrams PO daily. How many capsules are you going to give this patient with each dose? Well, we know by looking at this label, each capsule contains 250 milligrams. The ordered dose is 500 milligrams. So we're going to give 2 capsules to equal that dose. But now let's look at this medication label. We have the brand name medication, Imagimed, has a generic name of fictitious OMAD. It's an injection, so we're dealing with a solution. And it tells us that it has a dosage strength of 5 milligrams per 5 mLs, or also equivalent 1 milligram per 1 ml. So what that is saying is that for every milliliter you draw up in that syringe of that medication out of this vial, you are giving 1 milligram. So it's the equivalent of drawing up 5 mLs to give 5 milligrams. So let me test you again here. Let's say the doctor has ordered the patient to have a one-time dose of 2.5 milligrams of this medication. How much are you going to draw up? Well, we know that 1 milliliter equals 1 milligram. So we are going to draw up 2.5 milliliters, which will equal 2.5 milligrams. And then just to give you another example of looking at that dosage strength, let's look at this medication label. We have the brand name Fake Elixir with the generic name of Mixtrazole difecate, and we know that it's an oral solution. So it tells us that it has a dosage strength of 350 milligrams per 5 mLs. So what that means is that for every 5 mLs that you're measuring out, you're pouring out, you're giving the patient 350 milligrams of Fake Elixir. So let's say the doctor ordered the patient to have 700 milligrams once a day of this medication. How much would you pour out to give to the patient to equal that dose? Well, we know for every 5 milliliters you're pouring in there, there's 350 milligrams. So we need to give 700, 350 plus 350 is 700. So we would give 10 milliliters. Next is the route. On the medication label, you want to look to see if it specifies what route this medication should be given. Here we have a medication in the form of capsules. And generally speaking, capsules and tablets are understood to be given orally unless it's specified directly, because some medications may be supplied in a tablet form, but they need to be taken sublingual or the buccal route. For instance, like nitroglycerin, it's like these little tabs. We give them to patients who are having chest pain. That goes underneath the tongue. And on a bottle of nitroglycerin, it will actually say sublingual tablets. So always look at that information. Now there's other routes that medications can be given. For instance, here our label tells us it's via injection, and it says below that, it says for intravenous or intramuscular use. You could also, with some labels, it will tell you you can maybe give it sub-Q, so you can give it subcutaneous. In addition, other medications can be given via the eyes, the ears, rectally, vaginally. They can be given via inhalation, nasally, transdermal. So always double check that. Next is total amount or volume. And this is the total amount or volume of that medication in that container, bottle, or vial, whatever you have on hand. And here it tells us that there are a total of 50 capsules in this bottle. Now with solutions, the total amount will be written like with a volume. For instance, this vial of Imagimed, it tells us that it has a total of 5 milliliters in it. And over here with our fake elixir, it tells us that this bottle has a total of 100 milliliters in it after reconstitution. So once we have prepared it the way that the manufacturer wants us to prepare it, it should have a total of 100 milliliters in it. Next is the lot number and expiration date. So these two numbers are typically located together. So the lot number is helpful in identifying a recalled medication and to help the manufacturer track the medication. The expiration date tells you when the medication is expired. So as a nurse, you always want to check this, especially the expiration date, and you don't want to administer an expired medication to a patient, but discard it according to your facility's protocols. Next is the medication instructions. This is a section found on most labels that's going to give you some detailed instructions on the medication, such as dosages, how to prepare the medication, reconstitute it, storage details, etc. So let's look at this medication label of fake elixir. So over here, it tells us that this bottle contains a total of 7 grams of mixtrazole difecate. And that's just telling us that in this whole bottle of this medication, there's 7 grams of it. And it's telling us that in each 5 mLs, there's 350 milligrams of this medication. So that further gives you information. If you're a little unsure by looking at that front part of the label, that confirms how much is in each little dosage that you measure out. Then it says the dosage. See pamphlet included with the medication package. A lot of times manufacturers will include this little fold out piece of paper that will tell you detailed information about the drug if you need to know that. And then here, this is one of those ones that need to be reconstituted. So we have to prepare it in a specific way before we administer it. Right now, as it is, it's not ready to go. So it's telling us to add 80 mLs of water to the bottle to shake thoroughly, and this is going to prepare our 100 ml oral solution. So we want to do that before we give that to the patient. Now it's telling us that once we prepare this medication, it's going to expire in 14 days. So you definitely want to label this, let other people know when this was made and when it expires. Then it goes into detail about storage. It tells us that we need to keep it refrigerated between 35 to 46 degrees Fahrenheit and to keep it away from light. Next, you may see the manufacturer and the distributor's name and address, who made this medication and who is distributing it. It can be the same name or 2 different names. And then you will find a barcode on it, and this is used many times in the hospital setting to help identify the medication in the medication system and during administration. And lastly, we have the NDC number, the National Drug Code number. And this is the number the FDA uses to identify drugs. It has 3 sets of numbers that are hyphenated. The first set of numbers are assigned by by the FDA, and they are the labeler's code. The other numbers are given by the company, and the middle numbers are the product code, and the last numbers are the package code. So if you ever see those numbers on a label, you now know what they are. Okay, so if you'd like to test your knowledge some more on how to read medication labels, you can access the link in the YouTube description below. And thank you so much for watching.
You guys just watched the video with Sarah RN explaining the important parts of a medication label. So there's always going to be on the label the name of the pharmacy, the prescriber's name, that is going to be the doctor's name, the date the medication was filled, the prescription number. The prescription number is a lot of times what you're going to need when you're calling in refills. So on the medication communication, you can write on there the prescription number, the patient's name, the patient's date of birth, the order or directions, the medication's name, strength, dosage, and form, quantities, refills, and axillary labels. So axillary labels are side effect labels. These are very important for you to be aware of when you're handing out a medication, especially in our elderly who are already at an extreme fall risk. A lot of these medications do cause dizziness, vertigo, other things that could contribute to falls. So please make sure that you understand what you're giving and why you're giving it. Other very important axillary labels that you might have on a bottle or on a bubble pack, such as, don't drink with alcohol beverages. We do unfortunately get residents who struggle with consumption of alcohol. And so it is very important, regardless of the Del Monte location, whether it's a drug-free, alcohol-free location, or if it is a location that does allow the residents to partake in happy hour and stuff. It is really important that if you're at one of the locations that does partake in happy hour weekly, that you educate your resident on, the medication that they're receiving does not mix well with alcohol. And so that resident should either A, not partake in happy hour, or B, limit their use. And it's also very important that you communicate this with the physician, that the resident does, like to partake in happy hour. Other things such as do not crush or chew medications. We might not realize how fragile these medications are as far as the makeup components of them. But a lot of times, just simply crushing a medication will change the compound within that medication, and that medication, it might not have the same effectiveness, or it might interact with other medications differently. So it's really important that we follow that direction very closely. And the same with like taken with food, taken with water. Some of the foods will upset the stomach. Some foods will make them more dehydrated. So make sure you're paying attention to these labels. All right, so this is a point in time where you're going to pause the video and we're going to quiz you on what you have learned so far. Don't worry, this is just a quiz. It's not going to make or break you in your MedTech training at this point in time. It's just to make sure that you've absorbed what you have learned, and that you are understanding what you're learning. And maybe we need to go back and retouch something if you're not, obtaining the information very well. But here's another important thing I'm going to tell you right now is a key phrase that we're going to ask you to make sure you are truly watching this video, if you're watching this video on your own time. And that key phrase is butterflies. So butterflies are our keyword, key phrase to make sure you've watched this video. All right, quiz is done, pins are down, our minds are focused, and we are ready to move on. So, common medication errors. Um, Unfortunately, we're human and errors are going to happen. Our goal is to be 100% error free, but however, if an error occurs, we want to make sure that you know how to properly handle an error and how to effectively communicate said error. So, most common errors include never give medication with a written order only. Here's why. The doctor might have said one thing, and because you don't have true nursing training, and what I mean by that is you've gone to school for 18 months to 4 years and gotten your LVN, your RN, that you don't have all that knowledge and background to you to take a verbal order, and sometimes verbal orders are said differently than how they are written. So when a physician calls in with a medication change, no matter what type of medication change it is, whether it be hold an order, changing the frequency of an order, changing the dosage amount, never ever go ahead and act upon a verbal order without receiving that written order first. So, what you're going to say is, thank you, doctor, very much for calling this into us. But however, the policy of Del Monte is because, I am MedTech trained only. I'm not a licensed clinical vocational nurse or a registered nurse. I cannot accept a verbal phone order. Can you please fax that into our MedTech room? So doctors are going to understand that, and they're going to respect your honesty, because at the end of the day, they don't want to be held liable either for giving a written or a verbal order to somebody that really should have received a written order. So you also must wait for that order to come in. If it's not came in within 30 minutes, pick up that phone, call that physician, let the physician know. Also, while you're waiting for this, document in a progress note, Mrs. Smith's primary care physician, Dr. Jones, called in with a order change of once per day Xanax to 3 times per day Xanax, waiting for written order. So that way the verbal communication is documented, but it's also documented the medication is not going to be given in until verbal order is received. Once verbal order is received, then you can go back and through your progress notes, written order received, C medication order or CMAR or whatever. Okay, but we got to wait for that order. Wrong medication, especially with those that have names that sound alike. There are a lot of medications, including a lot of medical diagnoses that sound alike. So this is the other reason why we must wait for that written order. Wrong resident. You didn't use an ID on the MAR. You didn't check a bracelet. You didn't ask them for their name, their date of birth, their room number. You didn't do any identifying information. This does happen. And so that's why it's very important, if we are working in our memory care, we look at the picture on the medication record to ensure we have the right resident, because sometimes our residents don't give us the right names. Funny story, when I first started working for Del Monte, sweet little lady in one of our memory cares kept telling me her name was Ruby. And I believed her name was Ruby. And I kept saying Ruby this and Ruby that. And unfortunately, that was not her name. So It's very important that you guys do your due diligence and you check the picture against the MAR. Now, once you've been there a while, obviously you're going to know your residents and who they are, but it's still good to check that MAR. Wrong time, wrong route, um, wrong dosage, that also happens. This is part of your triple check. That's why, when you get a new medication, you're going to pull the MAR out, you're going to pull the label, and you're going to pull the order, and you're going to make sure all three match. At the beginning of the month, when we get a new MAR and the new orders come in, we're going to perform this triple check. At any point in time, if a medication doesn't look right in the bubble pack or in the bottle, we're going to pull out the MAR, the order, and the bubble pack or the bottle, and we're going to perform a triple check. Okay. Wrong preparation. Once again, it's all about how we prep that medication. So if we don't read the order or check the axillary notes and we go rogue and we crush a medication that is intended to be swallowed whole, this could cause an unfortunate side effect. So please make sure that we are doing that. Unavailable medication, a refill not completed. So we didn't report into our supervisor that a medication ran out. We didn't do our due diligence to make sure that medication came in. And now Mrs. Smith has been 4 days without her medication. Many of our residents are very fragile in the sense that they have medical issues that can result in death without their medications, blood pressure medications, blood clotting agents, such as Plavix and stuff, could have life-threatening consequences. So please make sure you are reporting medications that are out within 2 days or medications that are refused within 2 days. Errors of omission, meaning there is a medication technician provides medication services and resident care environment, but it just happens. So we just got to be very careful when we're doing our meds to make sure we're following all the orders. Failure to shake a medication. There are medications such as liquid antibiotics, such as inhalers, that if we don't mix them right, it could have consequences. Mixing, rolling, creating air bubbles, such as in insulins. So in our insulin pens, we're going to, do a click or two before we redial it in to make sure we remove air bubbles, all that fun stuff. Incorrect amounts of insulin given or incorrect amounts of fluid given with a medication. Given medications before a meal instead of with the meal or after a meal, and then failure to administer MDIs in the correct order. So meter dosed inhalers. There are inhalers that are albuterol, Zopanexes that really shouldn't, that should be given in a certain order, such as the meter dosed inhalers that are for the steroids. So make sure you follow all those directions correctly. This is where our triple check comes in. When we're doing the triple check, we're looking at the expiration dates on the bubble pack and or the bottle. Given a medication outside the expiration date, medications change dramatically as time goes on, and this can affect their effectiveness. Never administer a medication beyond the stop date. So, for example, Mrs. Smith might have been going in for a procedure, and maybe before her procedure, they ordered a certain type of pre what's the word I'm looking for? Preventative infection control. So maybe like an antibiotic, and it might have been a lower dose of type of an antibiotic. And then she had the procedure done, and now she is having a antibiotic post surgical event, and it might be a stronger antibiotic or a different type of antibiotic. And if we didn't stop the order the pre-surgical medication and we're still giving that one on top of the post, now she could be receiving too much of antibiotic that could cause some medication issues. So it's really important that when a medication says to stop on this date, that we stop it on this date. Um, Another thing, medications, if they have a new change in color, if their consistency, so some of our liquid medications, if all of a sudden they turn more thicker or thinner than what they had been, or if they've got a new odor to them that they hadn't had before, don't give that medication. Contact the pharmacy, contact the doctor, and document. Um, Administer only medications taken from properly labeled containers. So if the container that the medication comes in maybe doesn't look right, maybe there's a label on top of a label that wasn't communicated from another med tech that, hey, we had to relabel this medication because the label was wrong, or maybe the box that the medication came in looked like it had been opened prior to you guys getting it for the first time for first administration. Please be mindful of those. Never pre-pour medications. Only pour before giving. So a lot of our locations, they love to pre-pour, and the problem with pre-pouring is I know that Jenny's going to be short staffed on the PM shift. And so I'm going to help Jenny, and I'm going to put all of my residents' medications in these little tiny bubble cups, thinking that I'm doing something wonderful to help her out. The problem with that is that's when medication errors can occur. Not labels, sorry, lids with the resident's name written on a label could be mixed up, or I could, you know, not intentionally leave a medication out or give too much medication in a pre-pour. And now Jenny's coming in. Jenny is handing over that medication to Mrs. Smith, and Mrs. Smith takes that medication and it's the wrong medication and it has dire consequences. Unfortunately, it's not going to be on me. It's going to be on Jenny. It's going to be on Jenny because Jenny's the one who handed that medication. Jenny's the one who signed off that she opened and reviewed and made sure that medication was correct. In reality, Jenny didn't pour that medication. Jenny didn't prep that medication, but Jenny signed off that she did do so. So please bear in mind that pre-pouring is not okay, and that's when we're going to have a larger amount of medication errors. Never give medications without a written order, and this includes over-the-counter medications. So Mrs. Smith's daughter comes in. Oh, my mom's been having a headache. Here's some Tylenol. And we feel for Mrs. Smith. Mrs. Smith does have frequent headaches, but however, without us being pharmacy trained, we don't know. There might be medications that over-the-counter medications such as Tylenol could have a severe interaction with. So never ever give a medication without a written order, and this includes over-the-counter medications. Never borrow from another resident's medication. It is never okay to borrow some Lancets or some test strips from Mrs. Jones to give to Mrs. Smith. It's never okay to say, well, Mrs. Smith, I know, takes the exact same frequency and dosage of Xanax, and Mrs. Jones has some. So it's never okay to swap them out like that. Not only now have you potentially given medication that could be slightly different and you not know it to Mrs. Smith, but now Mrs. Jones is going to be short on her medication. So you're not really fixing the situation, you're creating a bigger situation. So never ever borrow or swap out medications with other residents. Always remain with the resident until all the medication is completely taken. So I've seen this like 100 times where the nurse will come in or the med tech will come in and Mrs. Smith is in the middle of her lunch. And so she's going to set the medication on Mrs. Smith's lunch tray. Miss Smith says, okay, I'll take my medication when I'm done eating. And the med tech walks out the room. Mrs. Smith forgets about the pills. The caregiver comes in and takes the tray away. And now Mrs. Smith has missed her lunchtime medications. So you got to make sure you physically watch Mrs. Smith take her medications. Never keep stock meds for just in case. So if there's, excessive amount of medication built up because maybe Mrs. Smith has refused a bunch of medications, we're not going to keep anything more than the recommended overflow for our med room. So we shouldn't see like 2 or 3 months worth of a medication in there for Mrs. Smith unless it comes from the pharmacy that way. Prepare medications one at a time. This goes back to the pre-pouring scenario that I was telling you guys about. We are only supposed to, as you guys recall from that video, do one resident's medications at a time. So if we're pre-pouring, chances are we got 4 or 5, 10, 20 medication little cups opened up at the time, and we're prepping them. And that's how medication errors happen. Give the medication to the individual as soon as you prepare it. Once again, back to pre-pouring, right? Someone could come in, and I would hope that nobody here at Del Monte would do this, right? But we pre-pour our medications, and I'm feeling a little pissed off at the oncoming med tech, and I'm gonna change some cups around with the caps, and so now the meds are all messed up. You just don't know, you guys. When we do a pre-pour, there's so many different things that could happen once we poured it. It's just not worth the risk at the end of the day. I would rather do a report that a medication was given an hour too late or an hour too soon than to give a report that a medication error happened and it resulted in an injury or a death of a resident. I cannot stress that enough. It's just not worth it, you guys. Document immediately whether a medication was refused, augmented, and why. And so I recommend, you take a couple of the refused medication reports and the medication communication sheets with you guys. So that way, if something is happening, you can write the name on it and briefly fill out some of the key components. So when you get back to the med room, you can finish it and send it off to the appropriate physicians and pharmacies and so forth. And never talk to others or ask them to talk to you when they're in the middle of a med pass. It's really important that when you're doing something so critical that your focus is only on this medication administration. And it's really important for us to support that med tech during that time frame. Administer medications when there is a documented allergy. So, for example, Mrs. Smith went to see a new neurologist, and The new neurologist maybe didn't realize that Mrs. Smith has a allergy to Xanax or Ativan. And Mrs. Smith comes back with an order for said Ativan. And Mrs. Smith's daughter decided to be helpful and stop off at a pharmacy and pick this up on the way in and not go through our Del Monte pharmacy. And so we get this new order for the medication, and we go, but wait a minute, Mrs. Smith does have a documented reaction to Xanax. What should the med tech do? I hope you're all saying do not give the medication. We don't give the medication. We immediately call that provider. We call that pharmacy. We document that we are holding said medication and the reasons why. And we make sure we put this into the communication log and we pass this all along to the next med tech coming on. And we also mark the bottle so that way it's not accidentally given by somebody else. If you use discounted or expired or contaminant medications. So if we know a medication was left outside of the refrigerator, we shouldn't be giving it, you guys. If we know that it was accidentally mixed with something else, we shouldn't be giving it. Always review vitals and trends prior to giving a high-risk medication. No, you should inform your director of nurses or your administrator or your clinical liaison if there's any changes in vitals, such as the glucose levels are really high, blood pressure is really high. You should also be informing the physicians as well so they can make adjustments either to the medication, but not with a verbal order. They must send you a written order. Or if they're going to make a decision to send Mrs. Smith out to the hospital. Interruptions. Once again, I'm picking up the phone. I'm interrupted. Medication error. Medication administrations that lead to med errors. There are refills that are not being done. Borrowing from other residents. A lot of this is repetitive, and it's repetitive for a reason. I'm bringing this up yet again 2 minutes later because it happens, and it happens frequently. All right. So we're going to go into a video on how to take vitals. Bear in mind that we are to assist our residents with vital taking. We are to never actually perform the vitals ourselves, but we can assist our residents in vitals. So here is the video, and here is the next video, or not video, but key phrase. Our key phrase is going to be the delta. Next key phrase is going to be the delta.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and today I want to demonstrate how to take vital signs. First, what you want to do is you want to gather your supplies. Typically what you're going to need is a stethoscope with a blood pressure cuff, along with a thermometer of some type, a pulse ox, a watch, and some gloves, along with a disinfectant wipe to clean the items that are not disposable. Then what you want to do is you want to perform hand hygiene and don the appropriate PPE if necessary. Like if your patient's in contact precautions, you'll want to put on the correct PPE. Now, what is collected during the vital sign measurement? Well, you'll be checking the patient's blood pressure, heart rate, respirations, and temperature. In addition, you'll be asking the patient their pain rating, which is sometimes referred to as the fifth vital sign, along with collecting their oxygen saturation. So I've arrived to the patient's exam room and I've performed hand hygiene. Now what I want to do is I want to introduce myself to the patient and tell them what we're going to be doing. So hello, my name is Sarah. I'm a nurse here and I want to be taking your vital signs. Is that okay with you?
Yes.
Okay, then you want to do your patient identifiers by looking at their armband, having them tell you their name and their date of birth. Then I like to start with the easiest thing, which is pain. And so I'm going to ask him his pain level. Now this is a very easy and important assessment tool because High pain ratings, if the patient is in pain, it can alter their vital signs. It can increase their heart rate, their blood pressure, and respirations. And it's really important, especially to ask a patient their pain level if they've just had surgery or some type of trauma. So to assess pain levels, you can do that with various scales. Most commonly, we use the 0 to 10 numerical scale. So can you tell me your pain, with 0 being no pain at all to 10 being the worst pain you've ever had? What's your pain rating?
0.
Okay, he says he's having no pain. That's easy. But let's say that he said that his pain rating was an 8. Well, you would want to ask some more questions. You would want to say, where's your pain located at? And please, can you describe it for me? Like, is it burning? Is it radiating? Things like that. And then you want to document that, the numerical rating, along with the words that the patient used to describe the pain and its location. Next, we're going to measure the patient's oxygenation status. And to do that, you can use a portable probe like this one, or one that connects to a bedside monitor. And to do that, you're going to place the device on the nail bed, because that's where it's going to obtain the reading. So make sure that you pick some fingers that have good circulation. They're nice and warm and pink. So we'll turn on our device and we will place it on the finger and let it get a reading. And here the patient's oxygen saturation is 97%. A normal oxygen saturation is anywhere between 95 to 100%. And below you can also see the heart rate as well, but here in a moment we will actually check the heart rate. And then you'll just want to remove the device, and if it's like a portable one like this, you'll want to clean it with a disinfectant wipe and then document your findings. Now we're going to collect the patient's body temperature. And some things you want to remember about body temperature is that in an adult it can vary. It can be anywhere between 97 to 99 degrees Fahrenheit, with the average being about 98.6 degrees Fahrenheit orally. And in an adult, it's considered a temperature if the temperature is greater than 100.4 degrees Fahrenheit. Now, the temperature reading will depend on the route that you use, and you can take a patient's temperature various ways, like orally, the forehead via the temporal artery, tympanically, which is via the ear, rectally, or axillary via the armpits. And a rule of thumb to remember is that rectal and tympanic temperatures will be 1 degree higher than the oral route, and temperatures that are collected via the axillary or the temporal route will be 1 degree lower than oral temperatures. So we're going to take the patient's temperature using the temporal artery, and we're going to use this device. So what you want to do first is you want to use a probe cover if your device has one. That just protects it from becoming contaminated. And what we're going to do is we're going to hold the probe flush up against the skin at the center of the forehead. We're going to take it and scan it across the forehead to the hairline and look at our reading. And before we do that, you want to make sure that the forehead is clear of any type of hair or anything, because this probe needs to be making contact with the skin. If anything comes into contact with it, it can throw off the reading. So we're going to put it flush against the skin and hold the button in on the device, and you'll hear it beeping, and scan it to the hairline and look at our temperature. Now, if your patient was sweating on the forehead, because a lot of times whenever patients have fevers, they can sweat, you would want to do it the same way. Probe up against the forehead in the middle, hold the button down, scan across the forehead to the hairline, but you're also going to go behind the ear, because sweating will decrease the temperature, and it's very vascular back here behind the ear, and that will just help us obtain a proper reading. Then what you're going to do is you're going to clean your device and document your finding. And if you didn't take it orally, you want to make sure you document the route that you actually took the temperature. Next, we're going to check the patient's pulse. And as we feel the pulse, we're going to be looking at several things. Of course, we're going to be counting the rate, but we're also going to be feeling the strength of the pulse. And we will be grading it on a 0 to 3 plus scale, with 0 being the pulse is absent, 1 plus weak, 2 plus normal, and 3 plus bounding. And the rhythm, is the pulse regular or is it irregular? Now in adults, the most common site to use to check the pulse is the radial artery because it's really easy to access. So it's found, what you want to do is find the thumb, and it's found below it in this wrist area along the radial bone, hence why we call it the radial artery. And whenever you're checking the pulse, have the patient, they can sit in bed, they can lie down, and you'll want to support their arm, extend it out and support it. And you're going to use your first 3 fingers to feel the pulse. Don't use your thumb. Your thumb actually has a pulse in it. So use your first 3 fingers and find it within that area I just told you. And lightly just touch it. Don't press too hard. And feel the bounding of the pulse. And what you want to do is you want to count it for 30 seconds if the pulse is regular and multiply that number by 2. If it's irregular, count it for 1 full minute. So his heart rate is 82, it's regular, and it's 2+. And a normal heart rate in an adult is 60 to 100 beats per minute. Now what we're going to do is we're going to keep our fingers here because what we want to do next is check the patient's respirations. And if you tell a patient that you're checking the respirations, they're going to alter the way that they're breathing. So we're going to stay in this same position and assess respirations. And when we're assessing respirations, we're looking at a couple things. First of all, the rate. A normal breathing rate in an adult is 12 to 20 breaths per minute. We're also looking at the depth. Is it labored or unlabored? And the rhythm. Are the breaths regular or irregular? And I have found the easiest way to do this is really look at the patient from the side and watch their gown, their clothes. Are they rising and falling? Because 1 rise and 1 fall equals 1 respiration. You can also sometimes just gently take your hand, put it on their back, and feel the rise and the fall of the chest. And so you will count that for 30 seconds if their breathing rate is regular, and then multiply that by 2. But if it was irregular, you would need to count for 1 full minute, and then document your findings. And lastly, what we're going to do is we're going to measure the blood pressure. And to do that, we want to make sure our patient is sitting down with their arm at heart level and their legs are uncrossed. Now, if they're lying in bed, you would want to make sure that this arm is at heart level. Then what we're going to do is we are going to get our stethoscope and our blood pressure cuff. And you want to make sure you get the right size cuff for your patient's arm, because if you use too big of a cuff or too small of a cuff, it can throw off the reading. And what we're going to do is we're going to palpate the brachial artery, because this is the artery we're going to be listening to get our blood pressure, because we're going to be getting our systolic number, which is that top number, and this is the first sound we hear, and then our diastolic number, which is the bottom number, and this is the point where we no longer hear the sound. So whenever we're looking at the gauge of our blood pressure cuff, we want to make sure we're really noting those points, because it's going to tell us our systolic and diastolic number. So what we're going to do is we're going to put our cuff on our patient, and we want to make sure we find the brachial artery. This is the artery we palpate that we'll be using to determine our blood pressure. And it's found in the bend of the arm. So we're going to find it, and it is located here. And we're going to look on our cuff, and our cuff has these arrows. And because this is the left arm, we're going to make sure that this arrow is pointing in that direction of where that artery is. So you're going to put the cuff up about 2 inches above the bend of the arm. First, what we want to do is we want to estimate the systolic pressure. So we want to find that number. To do that, we're going to palpate the brachial artery, and we're going to inflate the cuff until I no longer feel the brachial artery. And at that point, when I no longer feel it, I need to make sure I'm looking at this gauge to know that number, because that number is our estimated systolic pressure number. Then when I go to take the blood pressure, I'm going to inflate the cuff 30 millimeters of mercury more than that estimated number. Now, the whole reason for doing that is because we want to avoid missing the oscillatory gap that can occur in some patients. Not all patients have it, but some. And it's usually patients with hypertension, because the oscillatory gap is like this abnormal silence that can occur, and it will throw off whenever you actually hear that first sound, which is your systolic number. So I'm inflating the cuff by filling on the artery, and I'm going to note the point where I no longer fill the artery, which is about at the 100. Then I'm going to deflate it completely and wait about 30 to 60 seconds, and then we'll take the blood pressure. So our estimated systolic number is 100. Now I'm going to inflate the cuff to 130, and that will avoid missing the oscillatory gap if one was present. So I'm going to take my stethoscope, put it in my ears. You can use the bell or the diaphragm of your stethoscope. I like to use the bell because it's best at picking up low-pitched noises. So we're going to place that over the brachial artery. Do it lightly. Don't fully compress it because you can occlude the artery. Then we're going to inflate our cuff to 130 millimeters of mercury. And we're going to let it fall about 2 millimeters of mercury per second. And we're listening for that first sound, which is our systolic number. Okay, it's 104. And we're listening for that last sound. And it was 78. So the blood pressure is 104 over 78. Then once you have your reading, make sure you fully deflate the cuff full of air, and you're going to take the cuff off of your patient, of course, and clean it if it's not disposable, and you will document the blood pressure and what arm you took it in. Now, what are normal blood pressure readings? According to the American College of Cardiology 2017 updated guidelines, a normal blood pressure is a systolic less than 120 and a diastolic less than 80. Elevated blood pressure would be considered a systolic of 120 to 129 and a diastolic less than 80. Hypertension stage 1 would be a systolic of 130 to 139 or a diastolic 80 to 89, and hypertension stage 2 would be a systolic greater than 140 and a diastolic greater than 90. Okay, so that wraps up this demonstration on how to check vital signs. Thank you so much for watching, and don't forget to subscribe to our channel for more videos.
When prompted to take your blood pressure, please sit down on a chair near the blood pressure monitor and relax. Wrap the cuff around your left upper arm against the skin and with the Velcro on the outside. Ensure the tube is on the inside of your arm and the device is set to person A. Now rest your left arm on the table, press the start-stop button on the blood pressure monitor, and wait for the measurement to take place. It is quite normal for the cuff to get tight, but if alarmed, you can press the start button again to release the pressure and allow you to readjust the cuff. When the measurement is displayed on the screen of the blood pressure monitor, press the Upload button to transfer the reading to the telehealth hub. Once the measurement is announced from the telehealth hub, remove the cuff and press Next on the telehealth hub to continue.
What's up guys? In this video, we are going to discuss pretty much everything there is to know about pulse oximeters. Are you ready? Let's go! So since you're here watching this video, you may be wondering what exactly is a pulse oximeter. A pulse oximeter is a device that is used to quickly and easily monitor a patient's oxygen saturation. This means that it can measure the level of oxygen within the blood, specifically in arterial blood, without using any invasive means. It is typically a small portable device that clips onto the finger and provides a reading within seconds. And in addition to monitoring oxygen saturation, the device provides a heart rate measurement as well. Arterial blood flows to parts of the body from the heart, fresh with oxygen, where it diffuses to the surrounding tissues and cells. And if there is a lack of oxygen in the blood, that means that your body tissues will not be oxygenated properly and can be hazardous to your health. This can be an indication of serious pulmonary issues, and that is why it's so important to use a pulse oximeter. Respiratory therapists, as well as other healthcare professionals, use these portable devices to constantly monitor their patients' oxygenation levels and their heart rate. And these vital sign readings help provide a better understanding of the patient's overall cardiopulmonary status. And in some cases, it is also recommended that patients with cardiopulmonary problems keep their very own pulse oximeter at home. So if that's you and you're looking to purchase a pulse oximeter, I put a few links down below to some of our top recommendations. So how exactly does a pulse oximeter work? Pulse oximeters work on a simple but brilliant principle. So basically, the pulse oximeter shines a light through your finger, and by doing so, it can measure the amount of oxygen that's in your blood. Blood absorbs light, and there's a distinct difference between the wavelengths that go through oxygenated and deoxygenated blood. The finger clip of the pulse oximeter consists of a transmitting light source that emits a broad spectrum of light. And on the other side, there's a receiver that measures how much light passes through the finger. The diode on the receiving end is capable of detecting the wavelength of light. The internal circuits and processing components of the pulse oximeter do some calculations as well. That is because the device has to compensate for ambient light, so for example the light in your room or from the sun. It also has to compensate for the size of the finger and for the absorbance of the rest of the tissues. The device has a reference curve that is saved into its memory, and it uses this as a way to calibrate incoming readings and to normalize them so that you can get an accurate reading. And this helps to increase the precision of the results that it provides. So what does a pulse oximeter measure? Now, as we mentioned before, a pulse oximeter measures the oxygen saturation in the blood, and it gives a heart rate measurement. And when I say it measures the saturation of oxygen in the blood, I'm of course talking about arterial blood. More precisely, it measures the amount of oxygen that is being carried by hemoglobin, and this reading is known as the SpO2. So the primary function of a pulse oximeter is to measure oxygen saturation, and by doing so, the heart rate is automatically calculated alongside of the percentage of oxygen. So heart rate and oxygen saturation complement one another, and doctors and respiratory therapists rely on these readings to know how to properly treat their patients. So if you already have a pulse oximeter, you may be wondering how to use it. The best part of pulse oximetry is that it's non-invasive. Back in the day, doctors had to draw blood from the patient and perform several tests in order to find out the percentage of oxygen saturation. Now we can get that reading in a matter of seconds by using a pulse oximeter. All you have to do is clip the device on the middle finger or on a toe or even on an earlobe. Some models are even surface probes that can attach to the patient's forehead or even their chest. And once the device is attached and turned on, it will provide you with the readings in a matter of seconds. But to get reliable, realistic readings, you should try to minimize the patient's movement as much as possible. And also, if you're using a fingertip pulse oximeter, make sure that you're not wearing any nail polish if you're using it on yourself, or if you're a medical professional, make sure that the patient does not have on any nail polish as well. And another question that I hear quite often is, which finger is best for a pulse oximeter? If you didn't know, accuracy is often the biggest concern when it comes to measuring oxygen saturation with a pulse oximeter. Some studies were performed and it actually showed that the middle finger of the right hand gives the best accuracy. And surprisingly, the thumb of the right hand came in second. This is a bit of a surprise for doctors, respiratory therapists, and medical practitioners because the same study showed that about 80% of healthcare workers tend to clip the pulse oximeter to the patient's index finger. But with that all said, the differences were negligible, and any finger, as long as the device is secure on the finger, should give you an accurate reading. But if you had to choose, you can always go with the middle finger of the right hand. And since you've made it this far, you may be wondering, can you purchase a pulse oximeter on Amazon? And the answer is yes, of course you can. Each of the pulse oximeters that we recommend can be purchased on Amazon at a pretty affordable rate. Just be sure to check with your doctor and the manufacturer to make sure that the device meets your needs, especially as a healthcare professional. But if you want to see the ones that we recommend, just check out the links down below in the description. And now let's talk about the risk of using a pulse oximeter. Now thankfully there aren't any risk or dangers of using a pulse oximeter. The biggest concern is making sure that the device is giving an accurate reading. This is especially true for doctors, respiratory therapists, and medical professionals. That is because if the pulse oximeter gives inaccurate results, that could lead to poor patient treatment and care. And yes, while technically it is true that there aren't any dangers in using the device itself, like you're not going to get shocked or anything, but there could be some very serious dangers if the results are not in the normal ranges. And that is what we are going to talk about next. What are the normal ranges for a pulse oximeter? Now we've already discussed what pulse oximeters measure and how they work. Now we need to talk about what the normal ranges are for heart rate and oxygen saturation. The normal range for heart rate is 60 to 100 beats per minute. The normal range for oxygen saturation is 95 to 100%. Now keep in mind, these are the normal values for an average adult. These ranges differ depending on your age. So that means your normal range could be different than someone else's normal range depending on how old you are. And while the normal range for oxygen saturation is 95 to 100%, the level isn't considered to be dangerously low until it drops below 90%. In such a case, that is referred to as hypoxemia, which means that there is an abnormally low level of oxygen in the blood. Hypoxemia is treated with supplemental oxygen. So if you are a regular user of a pulse oximeter at home and the results that you are getting are consistently falling outside of the normal ranges, it would probably be wise for you to consider seeing your doctor or seeking professional medical advice. And the final step of using a pulse oximeter is to take your index finger and smash that like button. Okay, I'm just kidding. That's obviously not a step, but I would greatly appreciate it because it really helps support the channel. Alright guys, that my friends is pretty much everything you need to know about a pulse oximeter.